Thank you all for joining this room for our final rotation. The topic for this room is other health equity topics. We have two presenters in this room, and so we'll get started with our first one. Margaret Weiss, if you'd like to share your materials and take it away, the floor is yours.
Thanks so much, Jared. So I'm going to be presenting about our research looking at the relationships between urinary metals and diabetes traits among Mexican Americans living in Starr County, Texas. So a bit of background on this study. As many of us know, diabetes is a significant health threat. It affects millions of people. It has terrible complications, and it is a very expensive disease. Starr County, Texas is a small county located on the Texas-Mexico border, right along the Rio Grande River. And the people who live in Starr County are dramatically impacted by type 2 diabetes. Residents who live here have a 70% lifetime risk for developing diabetes, which is actually 30% higher than the national average for Hispanics living in the United States. Additionally, there's research to show that endocrine disruptors, specifically metals, are implicated as diabetes risk factors. So there is research to show that exposures to toxic metals or even alterations in essential metals can disrupt insulin production and disrupt insulin action. There's also data to show that minority populations, specifically Hispanics and Latinos, are predisposed to exposure to endocrine disruptors, including metals. So there are some current gaps in literature. And so the main ones that we will be addressing in this research are that Hispanic and Latinos are understudied with respect to environmental epidemiology and endocrine disruptor exposure, and that metals and other endocrine disruptors have been primarily assessed as individual exposures. So we know that we are not exposed in a vacuum. We are exposed to multiple toxins at a time. And so assessing co-exposure mixtures is becoming very important. So the overall objective of this study is to evaluate the impact of 8 urinary metals and their mixtures on continuous glycemic outcomes among non-diabetic adults who live in Starr County, Texas. So here are our methods. Our study population consisted of 414 individuals who had no missing data and they did not have type 2 diabetes. Here are our urinary metal exposures and then our continuous glycemic outcomes. HOMA stands for homeostatic measure of assessment, and HOMA beta represents beta cell functioning, HOMA S represents insulin sensitivity, and then HOMA IR represents insulin resistance. We also measured fasting plasma insulin, fasting glucose, and hemoglobin A1C. For our statistical analyses, we use multivariable linear regression in order to evaluate individual metals, and then we use quantile-based G computation to evaluate our mixture. Shown in this light blue box are our a priori confounders that were adjusted for in our models, and then below are some methodological details if anyone is interested in that. So here are our results. So table 1 shows our descriptive statistics and the characteristics of our study population. So most participants were female, obese, they were employed and had a high school education, and they did not smoke or drink. And then here are our metal analysis results. So we compared the highest quartile of exposure compared to the lowest quartile of exposure for all 8 metals, and these were the 4 significant effects. So we see a relationship between arsenic and copper with a reduction in beta cell functioning, whereas arsenic had an 8% reduction and copper had about a 10% reduction for the highest quartile of exposure. And then we also see a relationship between arsenic and molybdenum with a reduction in insulin resistance. So arsenic had about a 15% reduction in insulin resistance, and then molybdenum had about a 19% reduction in insulin resistance with significant trends. We did have some borderline significant effects. And so we see that cadmium has a borderline significant effect on reduction in beta cell functioning, and so does molybdenum as well. And then here are our mixture results. So we modeled our mixture as a simultaneous increase in all 8 metals at the same time. So the highest quartile of all 8 metals compared to the lowest quartile of all 8 metals. And we see similar trends that we see in the individual regression. And so in this bottom table, you can see that there is about an 8% reduction in beta cell functioning, and then again, about an 11% reduction in insulin resistance. So here are our conclusions. The overall conclusion of our study is that we found multiple metals, including arsenic, molybdenum, copper, and our overall 8-metal mixture to be associated with these alterations in steady state insulin glucose homeostasis. And this shows that toxic metals, so arsenic and cadmium, but along with essential metals, including molybdenum and copper, could influence glucose homeostasis. So there are some strengths and limitations to our study. The main strength being that this is a novel analysis of individual metal exposures and their mixtures on continuous metal diabetes associations. And this was done in a high-risk minority population. So as with any study, there are some limitations. The study was cross-sectional. And so because of that, there is limited inference based on temporality. We do have a limited sample size of only 414 individuals. And so these borderline associations that we're seeing with cadmium and molybdenum should be reevaluated in a larger cohort. And then with any observational study, there is a potential for any residual confounding due to unmeasured confounders. So some next steps that we're hoping to accomplish through my dissertation research is actually to look at these metals longitudinally. So there is a current ongoing study in Starr County. It's called the Diabetes Prevention and Microbiome Study. They are looking at diabetes traits and diabetes incidence over a 3-year period. And so we hope to use similar methods in order to look at metal exposure and diabetes incidence and diabetes traits within this population longitudinally. So the main impact of this study is that it provides evidence that there are environmental associations with diabetes pathophysiology, especially within high-risk minority populations. And understanding these exposures would benefit in terms of adding interventions for modifiable risk factors for a very devastating disease that impacts not just here in the United States, but globally. So I'd like to acknowledge my lab and my program, the Medical Scientist Training Program, and our funding. And I would like to thank the Minority Health Conference organizers for this presentation.
Thank you so much, Margaret. We've got about 4 minutes for any comments or questions. And so I'll pause if anyone would like to pose anything. And if not, I will bring up some of the questions that we discussed in the previous rotation. So if anyone has a question or comment, feel free to throw that out now.
I'm just curious to hear more about that community in Starr County and why that's, why is that where the study is? What's kind of unique to the folks as far as potential exposures in this community?
Yes, that's a great question. So we are very lucky to have great collaborators in Texas who have been looking at high-risk populations in Texas and in that state. And so there have been looking at the associations between diabetes prevalence and incidence within counties in Texas for the last 20 years or so. And this county really stood out because for some reason they have unprecedented rates of type 2 diabetes, 30% higher than the national average for other Hispanics living in the United States. And that is very poorly understood. We don't know why they are so heavily impacted by this disease. And so also, if you look at kind of just geographical maps of metal exposure, especially arsenic, you can see that the southern portion of Texas is actually a hotspot for arsenic exposure. Their well water and their groundwater is above the EPA and WHO standard for where arsenic should be at for safety levels. And so that's kind of what drove us towards reaching out to to those collaborators in Houston in order to look at the effects of these environmental chemicals on their diabetes risk.
Like Chloe said, that is some really important background. Thank you so much for sharing that. I had a question about kind of next steps and interventions. We talked in the previous sessions about how well water is a primary exposure, at least for arsenic in the population. And so I was wondering how interventions might differ between like a rural community like Starr County versus an urban community like Chicago. How might those interventions look different, and what might be the effect of those long term in removing this exposure?
Yeah, they would definitely be very different. So one thing that I learned with researching environmental health is actually that Chicago has some of the cleanest water in the world. Actually, we have great water treatment plants, and like making sure that the water supply is clean and free of chemicals. And so the difference between looking at rural communities is going to be drastically different than looking at urban communities where the water supplies are very different. And so in terms of intervention in rural towns and rural counties, it's more well water observation, water testing and treatment in terms of making sure that their water is kind of up to the standards of municipal water supplies, especially for private homeowners who have to deal with their own water. So in smaller counties and in smaller areas, the homeowner, it's the responsibility of the homeowner to make sure that their water supply is managed. And so that's very different for us living in urban areas where our water supply is managed by the city or the municipal area. And so their exposure patterns will be likely very different as well compared to rural communities versus urban, where in urban communities, you may be higher exposed through food consumption instead of water because we have cleaner water. So the interventions will definitely be different.
And those are some major implications for, environmental health going forward as we try to limit these exposures. So thank you so much for that really important information. We've got actually no time left for questions here. So I will transition into our next presentation. We've got about 10 minutes left in this session. And so we will spend that discussing Kareem's presentation. So Kareem, feel free to take it away.
All right, excellent. Can you guys hear me all right? All right, excellent. Hello, everybody. My name is Kareem Sharif, and I am very excited to talk with you all about our project on gender representation in medical student journals. To provide some introduction and a bit of a background, women make up the majority of medical school students in most high-income countries. Despite this, women remain underrepresented in senior academic leadership positions, including editorial boards of mainstream biomedical journals. Many studies show the underrepresentation of women in mainstream medical journals. However, gender representation in medical student journals is not well documented. Assessing diversity and inclusion in medical student journals is vital to understanding the point at which biases in academic medicine are established. Understanding when biases in medical authorship manifest may allow for a more targeted approach to alleviating these biases. This study explores diversity in medical student journals by examining gender representation on editorial boards, geographic region, and socioeconomic status of the country of origin. So to begin our search, we only included currently active medical student journals that are published in English with cumulative years in production of 2 or more. And editorial board related data included names of the number of editorial leadership positions, such as editor-in-chief, and other board members, such as deputy, section, and associate editors. We determined the gender of board members using a sequential approach. As for our results, a total of 21 medical student journals were included that have been established during the last decade. 17 of the evaluated are based in North America and Europe. All but one of the 19 journals originating from a specific country were published in high-income countries, the one outlier being Turkey, an upper middle-income country. Of the total 348 board members identified, 48.6% were women and 51.4% were men. And this leads us to our discussion, in which assessing diversity in medical student journals is vital to understanding the point at which gender, geographic, and socioeconomic biases in academic medicine are established. Females represent a majority of medical students in most of the countries, and despite our results not being statistically significant, taking this context into account, the authors are in agreement that a slight gender bias exists in medical student journals leadership. This is the first study to analyze gender representation among medical student journal leadership positions at large. And the evidence that gender bias exists during medical school can prove to be valuable in the wider context of minimizing gender disparities in the medical field. Previously, it was well established that large gender disparities exist in mainstream medical journal leadership, but it was unknown whether these disparities began during medical school or manifested at a later time point. Because this study provides preliminary evidence that the gender disparity in medical journal leadership begins to manifest during medical school, initiatives that aim to address gender disparities in medicine can then benefit from targeting current medical students. And that is it for my presentation. Thank you all very much for your time. And thank you to the Minority Health Conference team for setting this up.
Thank you so much, Kareem. We've got about 5 or 6 minutes for any comments or questions. And so again, I'll pause if the audience has anything. Otherwise, I will bring up some questions that we had discussed in previous rotations. So if anyone has comments or questions, feel free to ask those right now. So one of the topics that we had discussed in the previous rotations was, how to focus on gender inclusivity and considering, gender nonconformity in these types of studies, and how to, more precisely pinpoint folks' unique experiences with gender. And so, Kareem, if you have any comments that you'd like to share on that question from previous session, feel free to do so.
Yeah, absolutely. So as you mentioned, it's it's definitely a complex topic, and in order to conduct our study, we had to accept a level of possible error in order to obtain our results. And everything, we try to include procedures to determine our results with a high confidence interval. Everything short of calling and contacting the editorials in person and asking specifically about their gender identity. And one possible way where this possible confusion could be addressed would be to include possibly include pronouns next to leadership positions, names, so that no confusion can occur.
Thank you for that response. And I also came up with a new question. Sure. While you were discussing. And so I was just curious why most of the journals that you looked at were from high income countries, and kind of also building off of that, most of them are English speaking countries. I was just curious, how that came about and how that might have impacted the results of your research.
Yeah, absolutely. So with respect to our, the countries, the high income countries, that question came across in our analysis, and the conclusion or our thoughts on that was most lower income countries and lower middle income countries include their research, their mainstream medical research journals with their medical student journals in order to conserve on resources, because having two different journals could is very cost intensive. So many of these countries include one journal, and that did not qualify for the metrics of the study. Yeah, so that's kind of the explanation for why most countries are high income countries.
Could you conceive of an adjustment to the study design that might be more inclusive of low and middle income countries?
Absolutely. So if we were to include, so the premise of this study was to try to determine a point in time when the gender gap is being observed. So that's why we wanted to target specifically medical student journals as a distinct entity from mainstream biomedical journals. So from our research, most lower income countries did not have dedicated medical student journals. So that's what made our topic, that's kind of what made it difficult to include. But perhaps in separate studies, we will love to engage more with that section, with that topic as well.
We've got just over 1 minute left. If you'd like to, briefly wrap up with any comments about the importance of inclusion of gender and various geographies and income in medical research, I think that would be a great way to wrap things up and
Absolutely.
Yeah, move on. So go ahead, Kareem.
Absolutely. So I guess my initial thoughts was that with respects to equality, we always want to kind of achieve that. So with females being a significant and important contribution to medical literature, research, scientific research in general, we want to make sure that that kind of authority is represented in our leadership as well, people who are making executive decisions in these journals. So that's why I think this is a very important topic to discuss and possibly do some more research in.